That's a good crowd.
Good morning, everyone. Welcome to Pediatric Grand Round. It's nice to see a almost full room for the first time, probably ever, in this building. Thank you, Dr. J. Mehta, for driving the crowd.
Oh my gosh.
I think it was the croissants.
I hope there's a croissant left.
It hasn't worked before.
We didn't have croissants before. We have muffins. All right, Dr. J. Mehta is a pediatric rheumatologist and associate professor of pediatrics at the Children's Hospital of Philadelphia. He directs the Pediatric Rheumatology Fellowship at CHOP and is passionate about educating trainees and other faculty about pediatric rheumatology. He has a long list of training accomplishments, but he is very humble, so that is the simplest introduction I've given in a very long time. We want to acknowledge the grant from the Rheumatology Research Foundation through the American College of Rheumatology. We'd like to also acknowledge one of our med students who's sitting in the back there for facilitating this grant, actually. Catherine Leveley is in the back there. Please join me in welcoming Dr. Mehta, who will be here for 2 days. And doing a lot of different activities with the residents, didactics, board reviews, and a workshop. 1, 2, 3 tomorrow here in Mill Mountain Conference Room for a more hands-on workshop. You're welcome to join us. Please join me in welcoming Dr. J. Mehta.
Thanks, Vivian. Thank you, Catherine, for setting this up, and thank you all for having me. So, really excited to be here. So, I was here. First of all, I love that we're in a mall. I drove up and I was like, this is fantastic. This is the best place I've ever given a talk in. So, but speaking of malls, I was here about 5 years ago, and same sort of thing through the Rheumatology Research Foundation, and did the same thing where the night before I took the last flight of the day. It was like at 7 p.m. Got in at 8:30, and my son, who was 2 at the time, really wanted to help me pack. And so, which I was like, all right, that's, you can help me. So he's like throwing clothes into my suitcase. And again, it was the last flight of the day, so I was very, dressed very casually, like sweats and, whatever. And then I woke up the next morning, was getting ready, and then realized that one thing we had forgotten to pack in the process was shoes. And so I had flip-flops on at the time. And so I gave this talk in sort of this, but with flip-flops on. And it was great because everyone that I met throughout the course of the day really wanted to tell me where I could go buy some shoes that day. So they all directed me to the DSW. So when I pulled up to the mall, I was like, is this the mall with the DSW? But Catherine informed me it's a different mall. So fortunately, I did pack shoes this time, so we're good. But it was nice to be in a room full of pediatricians because no one cared.
But if you didn't, there's a shoe store just right next to you.
Okay, awesome. Thank you. So I've titled this Pediatric Rheumatology Red Flags and Red Herrings. And the idea of this is to kind of give an overview of, as a pediatric rheumatologist, I was talking to a couple of the residents just now, and that one of the things I love the most about it is the diagnostic aspect of it. That we really, I get to feel like I'm putting a puzzle together when I see a patient. So I'm using my history, I'm using the exam, and then I'm using specific lab tests to help me make a diagnosis. And that's really, really fun for me to get to do that. I get to do that every day. And then once we make a diagnosis, the treatments that we have are so much better than they used to be, and they're super safe for the most part. And they're really effective. So these targeted biologics that we're able to use right now have really revolutionized the field. And so it's a really, really fun field. And so that's my plug. I'll spend a little bit of time tomorrow talking a little bit more about what I love about pediatric rheumatology. But it's a phenomenal field for anyone thinking about it. Like Vivian said, I'm here for a couple days. If anyone wants to chat at any point, just let me know. I'm happy to set up. I have lots of sort of free time built in. So if anyone has questions, if they want to run patients by me, if they want to just talk about the field, about pediatrics, anything at all, I'm happy to chat. So please do let me know. All right. So my goals for this, I'm hoping that you will be able to identify common clinical presentations of autoimmune disease. Certainly I'm not going to be able to go through everything in an hour or so, but at least some of it. Want to discuss the significance of specific labs. I think that's one thing that people find really confusing about rheumatology. For example, the rheumatoid factor. It has rheumato in the name. It must be something that's important to us. Actually, it's not that important to us. And so it's not like this catch-all test for rheumatic disease. And I'll talk about that a little bit. Want to differentiate red flags, so things that should really like sort of raise your spidey sense, make you concerned, versus the red herrings, the things that really we don't actually care as much about in rheumatology. And then hopefully you have increased some confidence in ordering some of these screening labs. I don't expect that you're going to know everything at the end of this, but at least maybe have a little bit more confidence in what these labs mean. All right, and then please stop me along the way. I don't know if you're sort of accustomed to wait until we're done for questions, but I feel like if you have a question in the middle, then you're just thinking about your question the rest of the time. So just, raise your hand and ask, or just yell. All right, so how comfortable do you feel ordering and interpreting rheumatology tests? I know what I'm doing. I know what to order, but I'm often confused by the results. I have no idea what to order, so I just send everything, or I'm in the wrong talk, which is okay. Grab your croissant and you can leave. What do people think? I see a C.
B.
B, all right. Anyone A? In which case, you could just be on your phone the rest of the time. All right, anyone D? No. All right, so I've structured this in the form of a few cases. And the cases kind of build on each other, and there's some subtle differences, and I think this highlights how we think about things in rheumatology, is we look for the subtle differences, or the things that jump out. So a 12-year-old with 6 months of shoulder, wrist, hip, and knee pain. She has no joint swelling or morning stiffness, and so when I get a patient who comes to me with joint pain, which is really the most common complaint in my clinic, the first thing I ask about is morning symptoms, so morning stiffness. And I think that, as I think about my diagnostic kind of algorithm, that's really where I start to make the difference between inflammatory, where I worry about this, versus mechanical pain. So morning stiffness is more associated with inflammatory conditions. The pain is worse with activity and at night. The patient has frequent popping and snapping of her joints, and then she likes to sit in a W position. So what that means is she sort of sits with down on her knees with her legs sort of flayed out. I'm not going to demonstrate because I'll break something if I do that. So when you examine her, she has tenderness in her shoulders only. She has no swelling of any of her joints. She has increased range of motion over most of her joints. And then she's got some patellar maltracking, which I'll demonstrate during our joint exam workshop tomorrow. And then she's got pes planus. So this is what her foot looks like, and so you can see pretty clearly that there is no arch whatsoever. All right, great. She's really got no arch at all there, so that's what we call pes planus. And then this is what her hands look like. You can see I'm not flexible, so this is a good comparison, that her fingers sort of bow up like that. And she's also got hypermobility of her other joints. And so some of the ways that we look for hypermobility, again, I'll go through this tomorrow, but we try to thumb to the forearm like that, fifth digit past 90 degrees, elbow more than 10 degrees of hyperextension, knees more than 10 degrees of hyperextension, and then being able to put your palms flat on the ground when you bend over with your knees straight, which I'm definitely not going to demonstrate. So, all right, would you order labs in this patient? So, suspect non-immune disease, no symptoms are not concerning. Anyone A? B? I'm seeing head, okay.
C.
C, what's C? Call the rheumatologist.
Hypermobile.
So she's got hypermobile joints, yeah. So are there any geneticists in the room? No? Last time I met, there was a geneticist. Ehlers-Danlos, hypermobile, sort of hypermobile type Ehlers-Danlos is not really Ehlers-Danlos. I'll say that quietly, there is a geneticist here. But there's no genetic abnormality there. It's sort of a term for patients that are hypermobile to kind of give them a diagnosis. But it's not really associated with the vascular vessel problems. It's not associated with cardiac problems, things like that. And so those are patients that we don't tend to send for genetic testing. We may call them hypermobile Ehlers-Danlos, but then it sort of creates this, it can be problematic, but benign joint hypermobility is the term that we'll use. But not an autoimmune disease. So you do labs, even though everyone in this room said, I think correctly, that you wouldn't do labs, and you get a normal CBC, you get a sed rate that is very normal. Her RF is 17, with the upper limit of normal being 15, and then our ANA is 1 to 80. All right, so what does the positive RF indicate? She has juvenile arthritis. She may develop arthritis later in life. Not clinically significant, or I have no idea.
C.
All right. So rheumatoid factor is IgM or IgA or IgG that's directed against the FC portion of IgG. So I'm taking you back to second year med school, but there's an FAB portion which binds to antigen, there's the FC portion, and rheumatoid factor is one of these antibodies that's directed against the FC portion. Can be transient positive after viral infection, and this is a theme to our antibodies. Is that, as you all know, kids get lots of viruses, they develop a polyclonal response after viruses, and so they can get these transiently positive antibodies. In this patient, it's very low titer and not really concerning. We used to call JIA JRA, juvenile rheumatoid arthritis. We don't call it that anymore. One of the reasons is that the vast majority of these patients do not have positive rheumatoid factors. So it's really only positive about 3 to 5% of JIA. And when we see a patient with arthritis, and I'll talk about what it looks like when a patient has arthritis, if they have a positive rheumatoid factor, we need to test it and have it be positive twice, 12 weeks apart. And the reason is, again, because kids have transient positive RFs and other antibodies, and so we really want to make sure it's truly positive. But the vast majority of patients who have juvenile arthritis will not have positive RFs, and so don't rely on the RF to make a diagnosis of arthritis in a kid. So it is not a useful screening test. So it's neither sensitive, it's not specific, and so it's not a great screening test. And if you're in a low level positivity, probably not significant. If it's higher level positivity, then you might think about it, you might repeat it, but in a low level, we really don't worry about it. What about the ANA? So does the ANA indicate she's got some sort of autoimmune disease? She might develop lupus later in life, not clinically significant, or I have no idea.
D.
What do you say?
D.
D? Okay. Fair. Good. Let's keep going. Anyone else? C. C? Okay. Any other thoughts?
It's always possible she could get lupus later.
It's always possible. You can get lupus later in life. We don't know. I hope not. But I have somebody you can talk to if you do. All right. So the ANA is a screen for antibodies that are seen in some systemic autoimmune diseases. So lupus, Sjogren's, scleroderma. So these are the three where it's positive, where it's useful diagnostically. It is not this catch-all rheumatic disease test. So it is not, this patient's weird, let's do an ANA. Like that causes problems. Well, you can consult us and then we tell you it's not a problem. So you can see an ANA after an EBV coronavirus infection. Again, these antibodies can be positive after infections. EBV especially is associated with a lot of antibody production, and there's more and more data coming out that patients who have lupus, multiple sclerosis have some history of EBV in the past, and so there is some association with EBV and autoimmune diseases, but EBV can also just cause translate positive antibodies. So about 20% of people walking around have a positive ANA. So after joint pain is the most common reason that patients come to us, get referred to us, is that they've had a positive ANA. In some studies, the positive predictive value of an ANA is 1%, meaning that if you take 100 people, you do an ANA, it's positive, 1% of those patients will have 1% of those people will have a systemic autoimmune disease. So it is not a very good rule-out disease test. Again, ask questions if you're not. All right, so the gold standard for doing the ANA is an immunofluorescence, and I'll show you an example of what we do with the immunofluorescence. Titers. So the titer is basically the last level of dilution at which you still see positivity. The titer doesn't matter once you get past 1 to 80, which is when we start to consider it positive, except that as the titer goes up, the benign positive or false positive, it's more benign positive because it's really positive, but it doesn't mean anything. The benign positive rate goes down as the titer goes up. So we have patients who have lupus at a titer of 1 to 80, but most of those people are going to have no disease at all. And as you go up in the titer 1 to 160, 1 to 320, 1 to 640, that benign positive rate goes down. So it's more likely to be a true positive at the higher titers. But again, it's not, the titers don't sort of fluctuate. If you have a higher titer, it doesn't mean you have worse disease or anything like that. And then the pattern also gets reported. So the pattern is speckled, homogeneous, rim. You guys may have seen these and may have remembered these from med school. And so at CHOP, this is how we order this. It's the IFA, the anti-nuclear antibody with the reflux time. And then I'll talk about what this antibody profile is in a second. So this is how we do the immunofluorescence, and so they take a well, they put these cells at the bottom, these HEP2 cells, which are cells, from the lab that have giant nuclei, if you remember the anti-nuclear antibody, and then they look at and they add the patient's serum, and they look at if there's fluorescence, if they look at it under the microscope. And so this, with the patient A, what would their ANA be reported back as? 1 to 80, yep. And then patient B?
1.6.
So who has more antibody? B, right? You have to dilute it one more time before you don't see positivity anymore. Great. And these are the patterns that you will sometimes see. So up at the top, that's what we call a rim pattern. So you can see around the nucleus, there's fluorescence. So basically what you're doing is you're taking these HEP2 cells, you're putting patient's serum. Serum has antibodies, so if there's anti-nuclear antibodies, it's going to bind to the nucleus, and then you add something that fluoresces. And so you get this pattern. So you get that rim pattern at the top. Up here is the top right is a homogeneous pattern, so the whole nucleus is lighting up. This is a speckled pattern, and you have to sort of imagine a little bit that it's sort of more speckly than the homogeneous pattern. And then this is a nucleolar pattern where only the nucleoli inside the nucleus is lighting up. And so each of these can confer different concerns for specific diagnoses, but using the pattern has been replaced by some of the more specific antibody testing that we do that I'll talk about in a second. Questions about this? All right. So one of the options was she may develop lupus later in life, and so this is my favorite study in all of rheumatology. So this was now 20 years old. So what these researchers did is they, when you join the military, they take your blood and they bank it. And so what these folks did is they took people in the military that eventually got a diagnosis of lupus, and they went back and looked at their banked serum years before. And they found that some of them had positive antibodies, ANAs, up to 10 years before they got diagnosed with lupus, which I think is just a genius way to run a study. Like, you're literally going back in time, in a way. Not literally, sorry. Figuratively going back in time. So this is around the time that they got their first manifestation of lupus. This is time 0 when they got their diagnosis of lupus. And what they found is that green is ANAs, and about 50% of them had ANAs that were positive 5 years before they got diagnosed with lupus. Some of them, again, had antibodies that were positive 10 years before. And as they got closer to their diagnosis, they accumulated more of these autoantibodies. And then the anti-Smith turned positive, and I'll talk about what the anti-Smith is in a second, but turned positive in the year or so before. So the way that I use this study is when a patient, I just said that the ANA is the second most common reason that someone comes to me. So when I see someone with an ANA, if they look great, I tell them you look great, you don't need to come back and see me, but here are the things I want you to look out for, right? Because there is the possibility that you may develop lupus. Again, chances are you're not going to have any problems, but these are the things I want you to look out for. And some of the symptoms, and I'll talk about what are some of my red flag symptoms for autoimmune disease. All right, next case. So bottom line for that first one, RF in low titer, not positive, not concerning. ANA in a patient that's otherwise well, not concerning. And most people who have positive ANA don't have rheumatic disease. All right, so 3-year-old with 6 to 7 weeks of limp and refusal to walk. She wants to be carried often. Mom thinks her left knee is warm and maybe swollen. Her limp is worse in the morning. So I mentioned a second ago that that is a red flag sign, and then the limp improves over the course of the day. So this is what she looks like. So what do people see?
Big left.
What's that?
A big left knee.
Big left knee, exactly. People see that, so you look at the patellar margins, you can see really nicely there. You get blunting of the patellar margins there. She's got a big suprapatellar effusion, if you look there, and then a medial effusion. Those are the first two places, you'll see an effusion is suprapatellar and then medially. And tomorrow I'll demonstrate some of the ways that we look at knees. She's also probably got some finger swelling as well. Do you see that? So you do labs. Her CBC is normal, so just like the first patient. Her sert rate's slightly high, not at a level that's really super concerning. Same ANA, that's 1 to 80, and then she's got a negative rheumatoid factor, and negative Lyme. So whenever we see patients who have arthritis in the Northeast, we got to do a Lyme before. Do you all see Lyme here?
A Lyme.
Okay, all right. I thought so. I did my residency in Colorado, and like Lyme was not a thing at all there. And then I got to the Northeast, I was like, oh, I just got to start thinking about Lyme. All right, so what does the positive ANA mean? She's got JIA, she's got lupus, she might develop complications from her disease, or it's not clinically significant. So someone said C, someone said A. So for the person who said C, what are we thinking about? What's that? Just, okay. And then someone said A. All right, let's get into it. So you diagnosed her with JIA because she's had arthritis for a number of weeks. And the ways that you know she's got arthritis, she's got inflammatory joint pain, she's got swelling of a joint. It's been going on long enough that it's not necessarily an infection. You've ruled out Lyme. So the ANA, in patients who have arthritis, the ANA increases the risk of silent uveitis. And so again, taking you back to med school, you remember juvenile arthritis associated with uveitis. The uveitis tends to be silent. And so you think about your classic patient who's got uveitis, red, painful, photophobic eye. That's not how our patients with juvenile arthritis and uveitis present. They actually don't have any symptoms until they start losing vision, until they start doing like the screening tests at school. They can't see anything, or the teacher says they can't see the board, things like that. But most patients don't tend to have symptoms at all from their uveitis. And so one of the risk factors, the biggest risk factor is being ANA positive. The other risk factors are being young and being female, both of which this girl has. Bottom line for this, all JIA patients, or if you suspect JIA patients, so a patient with a lot of morning stiffness, maybe some swelling, though don't blame me if your joint exam isn't the best. But if you do suspect arthritis, send the patient to ophthalmology because this is the big comorbidity with this. This probably more than the joint disease leads to problems down the line with these patients. And so if you're thinking about JIA, send the patient to ophthalmology. How's your access to people? Good? Okay, great. Well, see you good. See you sort of shaking. Oh. Yeah, okay. Ideally, pediatric ophthalmology. Really recommend ophthalmology as opposed to optometry because we want them to get a slit lamp exam, which optometry often doesn't do. So, and this is a distinction. Patients say, oh, I went to see the eye doctor, but it's actually an optometrist. So if you can't get them in ophthalmology. There are some optometrists that do slit lamp exams, so good to know what they're doing. So this is one of the big complications of uveitis, and so what do people see? So I heard someone saying injected sclera. I think maybe a little bit injected, yeah. But really what we're seeing here is this irregular pupil, right? So that is what's called synechii. So those are adhesions between the lens and the cornea. So just like when you have gut inflammation, you can have adhesions that develop there. Same thing here, you can get adhesions in the eye that due to inflammation that then inhibit dilation and accommodation. And so this can be problematic. The other thing that you may see, it's maybe a little bit hard on the screen, but you see that right there? Anyone remember what that term is? A hypopion, collection of white cells at in the eye, as opposed to a hyphema, which is a collection of red blood cells. So these are complications of uveitis. This is something called band keratopathy, which is calcium deposition in a band-like distribution over the front of the eye, a complication of uveitis. And so just pointing those out that having uveitis can really lead to complications and vision loss. And so really important to send these patients to ophthalmology. So the rheumatoid factor. So, or what testing do we do in arthritis? So the rheumatoid factor, again, I just told you, doesn't tend to be positive in patients with arthritis. It is usually in older patients, so it's not a good screen for JIA. The anti-CCP antibodies, so those are seen in adults with rheumatoid arthritis. We do see those in patients once in a while. Again, it's very uncommonly positive, about 3% of the time or so. If they have it, it does confer a risk of erosive type arthritis. But again, it's not a screening test. It's really prognostic. So for that reason, the ANA, the rheumatoid factor, and the anti-CCP really should be considered risk or prognostic factors in patients with juvenile arthritis. So the ANA confers a risk of what? uveitis, the rheumatoid factor and the anti-CCP confer a risk of erosive arthritis. So anyone have any thoughts as to what is going on here? Or just tell me what you see.
Large right knee.
A very large right knee. Anyone know what gives you a knee this big? A giant effusion like this? So this is Lyme arthritis. So Lyme will give you the largest effusions you'll ever see in the knee. 90% of Lyme involves a knee, and so if you don't see knee arthritis, it's less likely to be Lyme. But we get these giant suprapatellar effusions in, and we can walk in the room and know this is Lyme when we see these patients. So this is testing that needs to be done in our patients with arthritis. So arthritis is a late manifestation of the Borrelia burgdorferi infection. So as opposed to the early manifestations, which are arthralgias, carditis, arthritis is a late manifestation. Important to keep in mind that half of patients with Lyme arthritis don't remember a tick bite or the bullseye rash. And if you think about it, we're so sensitized to Lyme here that if you get a tick bite, patients get seen, they get some doxy, they never develop the late manifestation. Same sort of thing with the bullseye rash. If you see it, we know what it is, they get doxy, they never develop the late manifestation. So most of these patients that have Lyme arthritis don't have any recollection of the tick bite or the rash. So don't rely on that when you're thinking about Lyme for your patients. And so if you have a patient that's got arthritis that lives in an endemic area or has traveled to an endemic area, we do the testing. You all just told me that this is an area they see lots of Lyme, so if you have a patient with arthritis, do it. And so the test is done, the CDC two-step process. So the first is an ELISA, and then and that's the more sensitive test, and then the confirmatory test is the Western blot, which is you look for 5 IgG bands. And it's a late manifestation, so it's going to be IgG bands. About 10% of patients will have some IgM still, but really for arthritis, it really should be the IgG that you see. So you may get a combination of IgM and IgG. All right. So takeaway from that first case, JIA, think about uveitis, and if they're ANA positive, send them to the ophthalmologist quickly. All right. Next case, a 14-year-old girl with a month of fatigue, arthralgias, and myalgias. The fatigue is getting in the way of her school attendance. She has arthralgias and myalgias diffusely, and then she's got intermittent joint swelling. So you see her on exam, she looks fatigued, her joints are tender, she has no swelling, and she's got some small lymph nodes that don't feel concerning to you. You do some labs, she's got a mild normocytic anemia, her sed rate is a little bit, or is pretty normal, and then her ANA is 1 to 160 speckled. So what's your interpretation of ANA? She's got a systemic autoimmune disease, she's got JIA, she has an infection. It's not clinically significant, or always the option of not knowing. Thoughts? Heard someone say C. Any other thoughts? Someone said A. No, I think someone just said it's not clinically significant. All right. So she gets seen by rheumatology. 3 weeks later, her symptoms have all resolved. The more specific autoantibody testing is unremarkable, and then she has EBV that shows that she's had a recent infection. So when you have a positive ANA, especially if the symptoms are short-lived, think about EBV and parvovirus. And then if you have more persistent symptoms, the symptoms that are lasting more than a few weeks, really outside the realm of what you might expect for EBV or parvovirus, then you can think about a more specific autoantibody panel. And so at CHOP, this is what we order, so the ANA antibody profile, which includes these things, so the anti-double-stranded DNA antibodies, anti-SMIF, anti-RMP, SSA, and SSB. So when do you suspect an autoimmune disease? So these are some of my red flags for when to think about it. So if you saw any of these in these patients, then these would be times to do more specific testing. So constitutional symptoms, prolonged fever, so fevers that aren't just for a couple of weeks. So even with some viral infections, as you all know, it can be common to have fevers for more than a week or so. But if you're starting to get more than a couple of weeks, then you want to think about an autoimmune disease or an autoinflammatory disease. Lymphadenopathy, it's persistent. Inflammatory joint pain. So I mentioned that that is one of my big red flags. So morning stiffness. So I'll ask if they have symptoms that are in the morning. Really, I think about if it's lasting more than 15 to 30 minutes or so. So 5-10 minutes of morning stiffness, not a big deal. Lots of people feel that. I imagine a lot of you in this room felt stiff in the morning for about a few minutes this morning. But really, if it's longer than 30 minutes or so, we start to worry. One or more persistent cytopenias. So cytopenias can be a sign of lupus and some other autoimmune diseases. So you want to think about that, especially with anemia, and then thrombocytopenia. You can see that with lupus. Chronic pleuritic or positional chest pain indicating serositis would be a sign of lupus or systemic JIA. Photosensitive malar or some unusual rash. And so when we say photosensitive, it's not as soon as they go out in the sun they get red. That's more like rosacea. But if they've been out in the sun for an hour or so, then their rash will come out and then it'll persist for a few days or weeks afterwards. That's more suggestive of lupus. Whereas like rosacea, when they get hot or when they go out in the sun, it'll come out, and then when they go back in, it'll get better. Or if they get upset, it comes out. That's often a distinction that we have to make. So it's really with prolonged sun exposure, and then the rash lasts for a while. And then severe multi-organ involvement. So patients in your ICU who you don't have a good explanation for, you want to think about autoimmune diseases for those patients. What else? So thrombosis or cardiovascular events. So fortunately in pediatrics we don't tend to see lots of thromboses, but if you do, you want to think about autoimmunity. Lupus, antiphospholipid antibodies are associated with thromboses. Alopecia, so with lupus you can get frontal alopecia, and so that should be on your differential if you have a patient with that. Raynaud's phenomenon, so white then blue then red, color changes that happen in the cold or with stress, and I'll show some pictures of Raynaud's a little bit later. Chronic urticaria angioedema can be associated with lupus and some other autoimmune diseases. And then recurrent pericarditis. And so when we think about Sjogren's disease, classically you think about Zika symptoms, so dry eyes and dry mouth. In kids, the most common way that they present with Sjogren's disease is actually with recurrent pericarditis. So repeated episodes of parotid swelling that may get diagnosed as infectious pericarditis, but then it keeps happening and then self-resolves over a couple weeks. So when I think about Sjogren's, that might be an indication to do an ANA and look for Sjogren's. Questions about any of these at all?
There's a question in the chat.
Oh, yeah.
Do you instruct patients to keep a temperature log to document fevers, and if so, what do you tell them to do?
It's a good question. So sometimes, so if we, I don't get into this a little bit, but since the question was raised, one of the things that we see patients for is recurrent fevers and questions about periodic fever syndromes, and so recurrent episodes of fevers where the patients are well in between episodes and the fever comes back. The pattern of fevers and the pattern of symptoms can be really helpful at making a diagnosis. Often we do genetic testing because these periodic fever syndromes are often genetic causes. But we'll have them keep a fever log in those cases to get a sense of like how high the fever is going, how long it's lasting, what other symptoms they have at the time. Because then that can clue us into which diagnosis the patient might have. So in those situations we do have them keep a fever log. Hopefully that answered the question. Feel free to add something if I didn't answer your question. And thank you for putting that in the chat, by the way. All right, so last case, the previous case, girl who had short-lived symptoms, ANA was positive, didn't mean anything, symptoms got better. 14-year-old with 1 month of fatigue, arthralgitis myalgia, so a month of now fatigue interfering with school attendance. She has diffuse arthralgias and myalgias, and then she's got persistent joint swelling. So not intermittent joint swelling, but really persistent joint swelling. You see her on exam, she looks tired, she's just tender all over. You see swelling in her hands, her wrists, her knees, and she's got some mild alopecia. So I'm already pointing out some of those red flags that I mentioned a second ago. You do lab, she's got lymphopenia, she's got anemia, so a couple cytopenias. Her creatinine's a little bit high. Her sed rate is now significantly elevated. So before I was talking about sed rates, 14 to 25 or so. Now we've got some elevation. Then her ANA positive, just like some of the other patients. But now you've got some of these other red flags that may make you a little bit more concerned with this particular ANA. All right, so your interpretation of the ANA. So I sort of led you down this a little bit, but she's got a systemic autoimmune disease, she's got JIA, she's got an infection, it's not clinically significant, or you could still say that you don't know. All right, good, we're listening. So any cytopenia can be a sign of systemic autoimmunity. So think about when you see cytopenia, especially if it's persistent. If you've got a better reason for the ANA, the patient's iron deficient, they're having heavy periods, things like that, then you don't need to go down the path of working them up. But if it's unexplained, then you want to think about it. And then certainly her serum creatinine being a little bit high suggests that she's got some renal disease. So when you're thinking about patients with, you're concerned about, so they have one of those red flag symptoms that I mentioned, you want to do a workup, things that we do, your CBC, your CMP, sed rate, your CRP. Interestingly, in lupus, there's often a discordance between the sed rate and the CRP. So the sed rate can be in the hundreds, and the CRP can be less than 1 in patients with lupus. And so that's kind of a red flag for lupus with us, is that discordant sed rate and CRP. And then we want to do a UA because they can have silent nephritis, and ideally you want it as a first morning void. So what we tell them to do, what I tell patients to do is pee in the toilet the night before they go to sleep. First thing they do in the morning, before they do anything else, pee in the cup and take it into the lab, because that's going to be your most ideal state, because I've seen plenty of patients who will do a late day urine and they have lots of proteinuria, and then you do it first thing in the morning and it's completely normal. And so you want that first morning void for UA. And it's important to, if you're thinking about looking for nephritis, important to do the UPC, the urine protein creatinine, and not the urinalysis, because the dip or that protein on the urinalysis isn't that accurate in terms of like actually estimating the amount of protein that they have, and so you really want to do the UPC if you're thinking about nephritis. So this patient, you're suspicious of something, you do the more specific autoantibody panel. So she's got a positive anti-double-strand DNA antibody, she's got a positive anti-Smith antibody, she's got low C3 and low C4, so what does she have? All right, lupus. Good. So what made you say that? What's on the side? Yeah, all of it. So lupus, a disease of broken tolerance, so immunologic tolerance. When our white cells grow up, when our immune system grows up, we learn don't attack yourself. That's tolerance, and lupus, for whatever reason, there's broken tolerance where you develop these anti-nuclear antibodies, and so we have evidence of broken tolerance. We should not be producing antibodies against double-stranded DNA, as you might imagine. We have lots of double-stranded DNA. That would be very bad. And anti-Smith, which is one of these other antibodies to nuclear proteins. The low C3 and C4 antibodies bind to antigens. That fixes complement, so complement follows the antibodies into the tissues, and so that's why your complement is low. So you have evidence of broken tolerance, and you have evidence of organ involvement with the creatinine. So she's got lupus. All right, so next case. So takeaways from that previous one, positive antibodies in the context of concerning symptoms, do more testing. 14-year-old with 1 month of fatigue, arthralgias and myalgias. The fatigue is getting in the way of her school attendance. So similar to what we've heard before. She's got diffuse arthralgias and myalgias. She's got greater than 10, I love that I started talking about the pain patient, someone walked out. She's got 10 out of 10 pain all the time. Nothing makes it better. She's got low-grade fevers. And my fellows will tell you I hate this term low-grade fevers, and they say it's 99 to 100. It's not a fever, it's low-grade temperature elevation. And then a maternal history of lupus. You see her exam, she looks fatigued, just like some of these other patients that we talked about. She's diffusely tender in her joints and muscles, especially of her back. She's got allodynia. Anyone want to tell me what allodynia is?
Pain with light touch.
Pain with light touch, exactly. So you touch her back, and she sort of jumps off the table. You sort of palpate her arms and legs, and it really bothers her. She's got no joint swelling. She's got no thyromegaly, lymphadenopathy, or hepatosplenomegaly. All right, so would you order an ANA? Someone, you're shaking your head no. Would anyone order an A? All right. What's that?
For the PHQ-9 for depression.
Yes, exactly. So no one said yes. Well, does anyone want to say? Okay. I imagine no one's going to jump out and say yes after the discussion we just had. Reasons people might order an ANA, that she's got fatigue, which is a symptom that we see in lupus. I'll often ask about the timing of the fatigue. And often these patients will say it's first thing in the morning when they wake up, they never feel rested. To me, that suggests more disordered sleep, kids on their phones at night, just not using good, doing good sleep hygiene. But if it's really sort of prominent later in the day, and they're sleeping well at night, but then they just can't get through their daily activities, that might suggest more of a inflammatory cause of fatigue. Some people will order AA because mom has lupus. The vast majority of patients with lupus, their family members are fine. Maybe her symptoms are vague, you need help deciding if this could be lupus, and then you might be getting some. So, for those of you who said no, why not? B. Okay. What other labs might you start with?
We'll make sure she doesn't have like anemia, so I might check like a CBC.
Yeah.
You can check for thyroid, then like you could check EBV too if she has any other symptoms of that.
Beautiful. Yep. Good. So you did labs anyway, even though you just said you wouldn't. This patient's like, can you really just, want to rule things out? So CBC, perfect, was normal. CMP was normal. Sed rate was normal. And then her ANA is 1 to 160, homogeneous. So interpretation of ANA. So I tell my fellows and residents, don't order a lab unless you know what you're going to do with it. So do you think she's got an autoimmune disease? Sounds like most people thought she didn't really have anything. So we're going to say D. So she's got lots of stressors. She's a high-achieving student taking 3 AP classes. She's a perfectionist type, a pleaser type. She's the kind of kid that all her friends come to with their problems. She gets into bed at 10 on her phone until midnight. She can't fall asleep. Anyone want to say what she's got?
Disrupted sleep.
She's got disordered sleep.
Long, unhappy life.
She's gonna have conversion disorder.
So maybe conversion disorder, but sort of our term for this is amplified musculoskeletal pain syndrome, pain amplification, the F word, fibromyalgia, all things that are used to talk about the same sort of thing. High degree of chronic pain without an explanation. It's sort of a somatization. We all know what we're talking about, right? So these patients, we will send them to PT/OT, we'll send them to mental health. We do not use medications in these patients. Our approach with intensive PT/OT and mental health treatment works phenomenally well for these patients, and so we don't use antidepressants, we don't use pain meds, because those things have side effects. Also, it can come back, and then if it comes back and you treat with meds, then it's always going to be a medication issue each time, and so we really try to empower them to get better. Yeah?
So I feel bad whenever these patients get to you, but can you give me your perspective? Do you feel like they tend to, getting to you, they do well because you're able to, in general, bring a lot of reassurance, or are you like hemming and hawing at the pediatrician that sent them to you? Can you give me kind of a perspective about how you guys feel about them? You like to see them because of the information you can give, or it tends to more validate their concerns?
Yeah, it's a great question, and I think, as pediatric rheumatologists, I will say that this is not my favorite population to see. There are people that really like this population. I don't, but I recognize that we have a role to play with them because we can reassure. We've had lots of experience with these patients. We know what treatment approach works, and you certainly can send them. But I think if you're suspecting amplified pain or fibromyalgia, then I think the best thing to do for them is actually to empower them and to get them started in physical therapy. And really, we're trying to get them. We talk about retraining the pain nerves so that they're not overactive and not sensing pain, and physical therapy can be really helpful there. So I think if you're suspicious of amplified pain, then I think getting them started in outpatient treatments can be helpful. But we have sort of a spiel that we give. We talk to them about the outcomes that we see, and so we can certainly see them. There are lots of really great resources on this, lots of great videos, handouts. The website, it was started by one of my former colleagues who started our pain program, stopchildhoodpain.org. And there's lots of really great handouts there and stuff that you can send patients to. Did that answer your question?
Yes. Okay. Thank you so much.
Yeah, of course. So a 16-year-old with a few months of color changes in her fingers, white then blue then red. She's got slight numbness to her fingers when it happens. Triggered by cold, quickly goes back to normal upon rewarming. This is what our hands look like. And so white up here, you can see specific fingers. And what you're noticing is that it's not the whole hand that's turning colors, it's really specific fingers. So let's think about Raynaud's. What it is, it's arterial vasospasm. So cold triggers arterial vasospasm. The idea is that if you're cold, you want to keep blood flowing to your organs, and so you shunt blood away from your extremities, so you vasospasm your extremities. So you turn white with the vasospasm, then when the tissues get deoxygenated, they turn blue, and then upon rewarming, they turn red. And the pain often happens upon rewarming with the red. So again, seeing specific fingertips or specific fingers, it's not the whole hand that's turning colors, because for arterial the distribution will be to the distal fingers there. Typically with mild Raynaud's, the thumb isn't affected. Weirdly enough, here you can see that the thumb is actually blue, which is kind of a red flag for more systemic disease. So she's got some faint livido on her arms, and then so the sort of lacy redness that can come with cold exposure that goes away on rewarming. She's got no digital pits or ulcerations. She's got normal, and I'll show you pictures of what that means. She's got normal nail fold capillaries, and then no sclerodactyly, no tightening of the fingers. So this is her livido. I don't know if you can see it from there, but it's kind of this laciness that comes out with the cold, and if you rewarm, and you can ask this, does this come and go with the cold? Does it get better when they rewarm? This is very common, not concerning at all, unless it's fixed. Meaning if it doesn't come and go. So you do some labs. Her CBC, her CMP, and her UA are normal. Her SET rate is 6. Her ANA is 1 to 40. So remember I told you that we really consider a 1 to 80 positive, and so I would not consider this positive. What would you do next? Refer rheumatology for the next available. Call rheumatology for an urgent evaluation, order an AA panel, or reassure. Reassure, because she's got Raynaud's phenomenon. So the ANA again is negative. Her other labs are reassuring. She doesn't have any other signs of lupus or scleroderma. She doesn't have cytopenias. So when I see patients with primary, or when I see patients with Raynaud's, I will do an ANA. Again, because of that study that I showed you, that it can predict the risk of development of other autoimmune diseases. So Raynaud's is one of my indications for doing an ANA. But in this patient, because her symptoms are otherwise normal, she's reassuring, her ANA is negative, this is probably primary Raynaud's. So similar patient, but color changes in the fingers, white, then blue, then red on one side now. As opposed to the previous girl where they go back to normal very quickly, these take a really long time to rewarm. The fingers stay color changed for a long time. Can actually occur both in the cold and when it's warm outside, so not just triggered by cold. She has no dyspnea, no dysphagia, no trouble swallowing, no trouble breathing. She's got myalgias. Her fingers are cool. She's got delayed cap refill. She's got livido over both her upper and lower extremities. She's got digital pits onto her fingers, and I'll show you what I mean by that. And then if you look at her fingers, her fingernails, she's got tortuosity and dropouts, so the nail fold capillaries look unusual. I'll show you what I'm looking for. And then tight skin on her fingertips. So this is her livido, so you can see she's got it both on the upper extremities there and then on the lower extremities. It's fixed. It doesn't come and go with when it's warm or cold out. It's really there all the time. This is not her. This patient's a little bit older, but this is sclerodactyly, the tightening of the fingertips that can happen. And then digital pitting scars. And so this is, you can see there, you can see the ulcerations and the scarring over there, and then you can see that there. There's these little scars on the tips of the fingers. Are people able to see this? Okay. If not. So this is when we're looking at the nail fold capillary. So we use a dermatoscope, which is, or you can use an ophthalmoscope that you put on 40x. And we're looking at the capillaries right by the nails there. And I should have brought one here so we could demonstrate. But normally you see these nice tight fine loops that go to the edge. Next time you're in clinic, use the ophthalmoscope and put it on 40 and look at your right here. Normally we see really nice loops. Here you're starting to see these like dilated loops, these giant loops, and then you've got some dropout where the loops aren't going to the edge there. And so this can be a sign of vascular insufficiency to the fingers. So you do some labs, she's got some anemia, her CMP and UA are normal, her SET rate's slightly high. She's got an ANA that's very positive in a centromere pattern, and their CK is slightly elevated. So what would you do next? So you've got a patient who's got a positive ANA, she's got bad Raynaud's, she's got sclerodactyly. So routine next available, urgent next available, ANA panel, or reassure.
It depends on how long that next available is.
For us, it would be urgent. Yeah, I agree. I think, we're lucky to have pretty ready access to pediatric rheumatology. I would say this is a urgent evaluation. So she was seen by rheumatology later that week, and she has a positive anti-SCL70 antibody. She has PFTs that show some restrictive lung disease. So anyone want to tell me what she's got? Scleroderma, exactly. So this would be a situation which you would call us. So if you suspect myositis, so this patient had muscle tenderness, her CK was slightly elevated. So other enzymes that we send if we suspect myositis, and so CK, LDH, AST, and aldolase. And the reason is that not all patients with myositis have elevated CKs, but they may have one of these other muscle enzymes. You may think about LDH, AST as coming from other places, but it does also come from muscle. And so some patients will have these elevated. And then if you're thinking about myositis, you can do some strength testing in your clinic. And so what I'll do is have them hold their head up off the table for 2 minutes, hold their leg up off the table for 2 minutes, not at the same time. Arm over their head for a minute, 10 sit-ups, 10 squats. And so what you do is have them lie flat on the table, lift their neck up, and see if they can hold it up for 2 minutes. Try when you get home, it's really hard. The leg up off the table for 2 minutes, and then their arm, and then sit-ups and squats. And if that's all good, if they can do that, and this is after they turn about 8 or so. Before this, they may not be able to do these things, but if they can do all these things, their strength is probably good. And the reason I do these as opposed to like manual muscle testing is manual muscle testing is really subjective. Like my 5 out of 5 strength is going to be different than yours, and it's hard to track it. And so this can be a really nice way to really sort of an objective measure of strength. All right, so last patient, 16-year-old with 2 weeks of pain and swelling in her hands. It's acute onset. There's no fever. She's had some recent siblings with some illness. She's got tenderness and swelling in all her MCPs and PIPs. She's got some erythema of her face. What do people think? Labs, refer to rheumatology, start steroids, start NSAIDs. We've got a girl with 2 weeks of joint swelling and pain. D, NSAIDs? Any other thoughts? All right. Why D?
I feel like if she's been hurting, I'd say let's try this first. That's easy to try. And start with that.
Let it. Try the easy thing first. Because kids, most things go away, which is nice. So you do some labs, even though you all correctly said that you wouldn't. So she's got a little bit of anemia. Her SET rate's 28. Her CRP's a little bit elevated, and her ANA is 1 to 80. So what do people think is going on? There you go. So you start daily NSAID, exactly right, David. She's got a positive parvo IgM, and then her symptoms get better after a month or so. So ANA, as I mentioned before, is often positive after parvo. If you've got acute onset polyarthritis of multiple joints that are affected, think about viruses. So parvo, EBV, rubella, HSV. If they've traveled chikungunya, so if they've traveled the Caribbean or to Asia, think about chikungunya, that can cause really, really severe joint pain. And then if it's migratory, think about post-strep, so acute rheumatic fever. So when we say migratory, What we mean is it shows up in one joint, and then a couple days later, it'll show up in another joint, but it's often additive. So if it starts in the knee, a couple days later, then it'll be a knee and an elbow. A couple days later, it'll be a knee, elbow, and wrist. And it's a migratory and additive. So if you're suspicious for a rheumatologic diagnosis, definitely want to do the CBC, the CRP, Ceterate CRP, the UA with the urine protein and creatinine. You might do the ANA depending on if you're thinking about lupus, if you're thinking about Sjogren's, if you're thinking about scleroderma. Maybe do a rheumatoid factor if the patient has arthritis. Again, it's prognostic, it's not diagnostic for arthritis. C3 and C4, if you're thinking about lupus, they'll be low. Want to do viral testing because you want to make sure that this isn't a recent EBV or parvovirus infection. You want to do muscle enzyme testing if you suspect myositis. So if the patient's weak or they're complaining about muscle tenderness. And then thyroid function often, especially in patients with lupus, they can have thyroid antibodies. And so you want to look at the thyroid function. So coming back to reasons to suspect autoimmune disease, again, constitutional symptoms that last for a long time, inflammatory joint pain, most important question you can ask. If you see cytopenias, pleuritic or persistent chest pain, does your chest pain get worse when you lie flat? Does it get better when you sit up? Chest pain with breathing in, photosensitive rash, severe multi-organ involvement, thrombosis, alopecia, Raynaud's, coronary care, pericarditis. So things you might want to do a little bit differently if you suspect autoimmune disease or these targeted labs. Think about EBV and parvo in patients who have joint complaints, especially if they're short-lived, acute onset. Do a thorough review of systems and history. Tell you all that. Make sure you look at their skin and joints. And then, don't send a ANA and RARF reflexively if you think it's rheumatologic. Really think about doing these things targeted. If you've got a high suspicion for JIA, think about the rheumatoid factor. And then if you've got one of these symptoms concerning for lupus, Sjogren's, or scleroderma. And then when to call a rheumatologist. And so if you have multiple or severe lab abnormalities, if the symptoms are getting in the way of their daily life, if you need help on what further workup to do, always you can email me. My email's at the front of this. But and then if you need your patient seen soon. All right. Questions? Obviously, you get my email if you need it. We have a couple minutes for questions or thoughts on any of that.
So you talk about getting a rheumatoid factor if you're concerned for JIA. With the low rates of it actually being positive, what's the actual specificity of the test when you get it?
The specificity of a rheumatoid factor, so it's a good question. It's hard to say in the right context. If you've got someone with, so I'll say in adult RA, which is probably the best data that we have, it's like 70% specific or so. So it's still not a great test in adults either, but it's even an even worse test in kids. So I'd say it's not, but if it's in a high titer, if it's positive, and you've got a patient who's got arthritis, then I think that's it's pretty specific. Does that answer your question? Yeah.
With the EBV titers, do you ever feel like you could be missing something by assuming it's just EBV, given how ubiquitous EBV, like having IgG, for example, could be?
Yeah, it's a fantastic question. So I think, I think if you just see evidence of past infection, I think, hard to know what to do with that. And I would say, look for other causes, but really looking for sort of those symptoms or those findings of a recent infection. And don't ask me what those are, because I just have to look up the EBV testing. How to interpret them.
I just want to publicly, while we're still online, thank you for filling the room.
Oh yeah, thanks for
This
coming.
is great. I counted 25 or so in here. For those online who didn't join and want to join next time, whatever we got going, we do have two sides to this Mill Mountain room. We can open it up and fill it up. So thank you very much for
It's a great room,
wonderful
great breakfast.
presentation.
It's lots of nice people in here. It's a nice painting of mountains in the back.
Yeah, this is more basic science. If we think of antibodies as reacting mostly to things on the cell surface, how do patients develop antibodies to DNA?
Yeah, so that is a complicated question that a lot of people are thinking about. Our sort of cop-out answer is genetics and environment. That's sort of our reason for everything. But there are certainly some genetic predispositions to breaking tolerance early on, and then there are things that you sort of go into this cycle where you develop more antibodies. So, for example, why does UV light flare lupus? It doesn't just flare the skin disease; it can actually flare the systemic disease. And so, UV light causes keratinocyte necrosis, and one of the problems in lupus is you don't handle necrosing cells well, and so like that normal process of cell death, that you kind of do everything tidily and the cell dies. In lupus, that's disordered, and so actually you release antigens, so nuclear antigens out into the periphery, and so then when you have circulating antibodies, then you bind to that. So that's what causes that flare, is you're sort of like UV light is releasing antigens, and you already have pre-existing antibodies to those. But why people develop those antibodies in the first place, I think it's not quite clear. But again, some genetic predisposition and some environmental factors. Yeah, I don't have a great answer for you, but one day we may. Thank you all. Appreciate everyone's engagement.